Rajpal Singh. I'm the head of cardiology at Fortis Hospitals, Bannerghatta Road in Bangalore. Bangalore is a beautiful city in the south of India, very well connected with Africa, and we have 5 hospitals under the Fortis brand. In my city, we have around 9 hospitals which belong to the Fortis cluster. And in fact, we have just had a very nice meeting, a workshop, just day before about how we can optimize cardiac related, heart failure related issues, as well as take steps forward in terms of cardiac transplant and so on. So this is a very timely talk. Am I audible and clear?
Yes, sir.
Fantastic. Okay. So the topic of for today, as Varun asked me to speak about something which is relevant, and I thought that there's nothing more relevant than heart failure in this day and age, and the detection and management of heart failure, what needs to be done, and when to refer, I thought would be a more appropriate thing for this discussion, because we know where we are going. I'm someone who's trained in the UK. I spent 17 long years in the UK. I was a consultant there, and I trained, and I've come back to India for the past 15 years. So majority of my line of thinking is based upon the European guidelines and contributed partly by the American guidelines as well. So the reference base for this talk would be both the 2021 ESC guidelines as well as the 23 focused guidelines for the heart failure. And whenever we talk about heart failure or any form of therapy, we should be very clear about what is it that we are recommending. And this is again based upon the class of recommendations, whether it's a class 1 recommendation or a class 3 recommendation. Class 1 being where it is very evidence-based, and we know that the given therapy is beneficial, useful, and more effective. And class 3, at the other hand, is the therapy which can be harmful. There is no strong evidence and therefore not recommended. And then we look at the levels of evidence. We look at level A evidence, B or C. Level A is very strong evidence in terms of randomized controlled trial data or meta-analysis. Level 2 is just a single but still a randomized controlled trial data or a very large non-randomized controlled data. And level C is generally something that is looked at in terms of consensus opinions from experts and so. So when you see my slides in the coming few minutes, it has always got some recommendation behind it, whether it's level 1 or level 3, class 1 or class C, and so we can then push upon these discussions further. See, heart failure is something which one needs to know. This is something which stays. If you look at the epidemiology, these are very old slides. And in these very old slides, you know that the prevalence of heart failure increases with age. Now, if you are younger, the prevalence of heart failure is in decibels. And if you are older, it becomes into early double digits and into larger double digits. So it's very clear that the younger the age, prevalence of heart failure is less. The older the age, prevalence of heart failure is high. We also know that the incidence is high in men compared to women, mainly because of their lifestyle, their risk factors, and their cardiovascular risk factors being higher. And this, as I said, the incidence is much increases with age as well. And if you look at this very old data, this we are talking at data of nearly 8 or 10 years ago. In fact, I've been using this slide for the past 15 years, I think. And if you look, this is all American data. This is based on general population. If you look at an undiagnosed heart failure patient, untreated heart failure patient, whether it's a man or a woman, whether it's European data or American data, the 1-year mortality, if you have got untreated heart failure, is very high. And if you look at 5-year mortality, even with the then treatment, the mortality was significant. So there is a great need and immense requirement for this to be diagnosed early. And this is very common, whether it's India, Europe, America, or Africa. This is one of the most common presentations in the community and in the hospital setup. About 30% of patients who come in with shortness of breath in the emergency are those patients who've got heart failure of some sort, either an acute heart failure or exacerbations of established chronic heart failure. It is still underdiagnosed and undertreated, as you would find that a lot of people still think that this is not necessarily heart failure. And even if it is heart failure, I've had doctors, senior doctors in who still give low doses of Lasix. Some like to give just digoxin, some like to give some cod liver oil capsules for heart failure management, when we know that there is better treatment. And undiagnosed heart failure, it has got malignancy rates, has got mortality rates, which is comparable to most common malignancies. And I'll show you in the next slide what it means. Treatment of heart failure has progressively improved. Now, in the 80s, we used to think of 3Ds. We used to give them diuretics, we used to give digoxin, and we would wait for their death. In the 90s, once the ACE inhibitors came in, it made a difference in that they started giving loop diuretics and ACE inhibitors. We demonstrated that there was a benefit, and this became a routine. In the 2000s, it was diuretics, ACE inhibitors, beta blockers, and devices. As I always tell in my talks, when I started training in cardiology, to give a beta blocker to a heart failure patient was a crime. By the time I finished my training or was coming to the end of my training, the entire scenario changed. It was criminal not to give a beta blocker in patients diagnosed with heart failure. So it became a huge difference, and beta blockers made a change. Then came devices also, heart failure devices, CRT devices, defibrillators. These all showed that they improve outcomes and better outcomes. Now, in the last 10 years, you have seen that it is drugs, which is very good drugs, optimal heart failure medications. We have devices. We then bridge these patients who survive and who are still symptomatic with assist devices, and transplants have become a norm in advanced heart failure patients. And I hope in the coming 15 to 20 minutes, we'll go through these slides and the data for this. Why is heart failure becoming so common? Well, this is a very nice German slide from a German presentation I picked up at the EuroPCR a couple of years ago. And you can see that heart failure is moving to the center stage. Why? Because we are now able to treat myocardial infarctions better. Yes, better, but not optimally, because we still have long door to balloon times or needle to thrombolysis times. But still, we are able to salvage myocardium and save that acute death or reduce the chance of that, as a result of which people are living much longer and the myocardium is getting degenerated. And you can see to the right of this slide, you've got more patients who are surviving and presenting with heart failures. To the left of the slide, reduced mortality with acute myocardial infarctions. To the right of the slide is heart failure patients increasing. And this is a real pandemic that we're looking at. And if you see, the whole thing is because it's a vicious cycle. It's a vicious cycle of heart failure. You produce cardiac injury, you get myocardial pump failure. When you get myocardial pump failure, you have either carotid baroreceptor stimulation or reduced renal perfusion, as a result of which you've got two limbs. You've got the sympathetic nervous system, which gets activated, and you've got the renin-angiotensin system, which gets activated. Both of these are detrimental for the heart. The sympathetic nervous system increases the heart rate and thereby increases myocardial toxicity and produces further left ventricular dysfunction. Activation of the renin-angiotensin system also has an adverse event. It increases the afterload by vasoconstriction, by activation of the renin-angiotensin system. It also increases the preload by increasing having an alteration of the hemodynamics. This further leads to heart failure, and this entire cycle leads one to another unless it has been treated. And this is a very good slide in which we know that, look, we can treat each of these limbs at different ways with different class of drugs and thereby arrest this process. And that is what should be done when you have a patient with acute heart failure who presents. We have to first make the diagnosis. We have to make the diagnosis by looking at the patient's history, by looking at their symptoms, and looking at the risk profile. And we are supported by doing this, by doing an ECG, by doing an echocardiogram, and by doing routine investigations like chest X-ray or biochemical markers. one of the most important biochemical marker that has come into the system and into the practice in diagnosing heart failure, particularly those that you see in the emergency room or in your OPD practices, is routine use of the natriuretic peptide. You should be using BNP levels, and this does not get elevated to a high extent in any other condition but heart failure. Only when the heart is under stretch, either because of left ventricular failure or because of congestive cardiac failure, you get this. If you've got pro-BNP levels or BNP levels which are low, which is less than 300, you know that this patient does not have acute heart failure. Whereas if you had patients who have pro-BNP, BNP levels, whichever is available for you, if they're elevated, you know that this is something that requires treatment. And this is what is the protocol that is advised by the European Heart Society. Your diagnostic algorithm for patients: if you got a person who has got shortness of breath, you do a clinical assessment, you take a physical examination, you do ECGs, and you also do pro-BNP natriuretic peptide levels. Either you do a BNP level or a pro-BNP level. Both of them are useful, whichever is easily available to you. Once that is done, if you've got a patient whose BNP levels are negative, ECG is normal, a 12-lead ECG is normal, you've more or less ruled out acute heart failure as a cause for these symptoms. If these are increased, then you can take a step further and get a transthoracic echocardiogram. I don't know per se how easily available transthoracic echocardiogram would be in your place, but it is something which is something that can be picked up. And if you are cardiologists or general physicians who have interest in cardiology, this is something you can come across to us. In about 2 or 3 weeks, we can give you a crash course about how to do echocardiogram, what is to be picked up on echocardiography, and that would help you in diagnosing these patients. So once heart failure is confirmed, then you look at the cause and classify it. The current guidelines no longer tells you systolic dysfunction, diastolic dysfunction. That's old jargon. Now we have patients with heart failure with reduced ejection fraction. That is clearly an EF less than 40%. Patients with mildly reduced ejection fraction, those who do not have a normal echo, neither have got significant LV dysfunction. That's the EF between 41 to 49%. And then you've got patients with preserved ejection fraction. The good old so-called diastolic dysfunction patients are now termed as patients with heart failure with preserved ejection fraction, where the EF is more than 50%. And accordingly, you can then evaluate for the precipitating factors and so on. So how do we identify these patients? Am I still clear and audible? Or am I going too fast?
No, sir, you're clear and audible.
Fantastic, fantastic. So what is your role? You want to catch patients in stage A, that is at-risk patients. There's nothing better than having a prophylactic approach to heart failure, because once heart failure is established, treating it is not that easy. So catch hold of those patients. If you have practice, look at those patients who might be at risk. Who are the ones who are at risk, who do not have any current symptoms? Those are the patients with a high risk profile. The obese patients, the patients with hypertension, the patients with family history of premature vascular disease, or patients who've had a myocardial infarction or unstable angina, diabetic patients, patients who've got a family history of cardiomyopathy, patients who've got exposure to chemotherapy, or so on. These are the patients who are at risk. So it is good to pick these patients up early. Do an ECG, do an echocardiogram, do a pro-BNP. If these are all normal, then you know this patient is not has not developed. But do not stop at that. Ask them to come once a year. Have this routine check, because heart failure is something which has got a very insidious onset. In some patients, it is dramatic. In most patients, it can be insidious, particularly your diabetic patients, particularly your obese patients, your smokers, your patients with excess alcohol intake. They don't realize until it hits them when gradually. So then you go to those patients who've got the stage 2 or stage B, where you've got heart failure patients. These are patients who have got minimal symptoms, or very little symptoms, but they have got structural heart disease. Now, for example, it might be rheumatic heart disease. Patients who've got a mitral stenosis or mitral regurgitation, they've got increased filling pressures. And if you find that these are patients who have got to their biochemical markers, and if you find that their natriuretic peptide levels is more in 800, 1200, then you know that even in the absence of patients in symptoms, these patients are developing evidence of heart failure. And again, treating them early, picking them early, makes a huge difference. Then you get the standard stage 3 patients where you have got symptomatic heart failure. They either present acutely or have got chronic symptoms. And those patients, some of them who've missed all these 3 stages and present late with advanced heart failure patients, which is orthopnea, PND requiring multiple hospital admissions. So identify your patients early, recognize these patients, and start treating them. And the guidelines are very clear. I'm not sure this slide projects very clearly, but routine use of pro-BNP levels is used, and this is what the recommendation says. It's all class 1A indications, so there is level of recommendation is 1. The level of evidence is also high class. So in patients presenting with dyspnea, i.e. shortness of breath, pro-BNP levels or natriuretic or anti-BNP levels is very useful in diagnosing and also in excluding heart failure. It is equally important to take the stress of the patient's mind about them not having heart failure. So use of this biochemical marker is very useful. In those patients who got established heart failure, again, having a baseline BNP levels and monitoring it with each admission is also very useful for risk stratification. We know that patients who've got a persistently elevated pro-BNP levels are at a higher risk of worsening heart failure and cardiac death. Thereby, looking at that is also recommended. In those patients who are hospitalized, you can use this as a marker between admission and discharge levels as well to see if there is pro-BNP levels are dropping. In my heart failure clinic, we routinely do pro-BNP levels at every visit. Visit 1, visit 2, visit 3, whenever they come, in addition to having a creatinine level check, a hemoglobin level check, we do a pro-BNP level. And we are able to demonstrate, or we are able to assess the patient. Is this patient settling down, or the patient has got a spike, so maybe he's got a fluid overload? Is there something that we can do for these? In those patients who've got risk of developing heart failure, again, as I said, you can use this to pick up those patients at risk, and you can also use this in patients who've been hospitalized to decide whether this is a patient wherein you have to monitor them a bit more closely compared to the other patients or not. So what are the investigations that you have to do in heart failure patients? As I said earlier, the recommendations are clinical examination first, physical examination, biochemical markers, and then if you want to look at other things like in patients who are at risk, then you want to look at their other factors, like as what is the cause for their heart failure? Is it anemia? Is it liver toxicity because of alcohol excess? Is it because they have developed renal failure, and that's the thing? Is it a composite of other factors such as hypothyroidism or hyperthyroidism? Again, these are things that should be done. So in most of your patients, you would want to do a full blood count, you want to check the renal functions, you want to check their liver function test, you want to do the thyroid function test, you would want to do an 12-lead ECG, you would want to do an echocardiogram. This would suffice as a baseline investigation for those patients. In patients who've got abnormal ECGs and who've got collaborative history of exertional angina, these patients should be evaluated early with an invasive angiogram, a myocardial perfusion scan, or other things like a cardiac MRI or a CT angiogram. And this is something which is very important. Now we then take on to the next group of patients wherein there is a family history of premature vascular disease or a family history of heart failure. Now it may be those patients who've got genetic or inherited cardiomyopathies such as Brugada, hypertrophic cardiomyopathy, so on. Now tomorrow or day after, I think I'm upgrading a patient who's got sarcoid. He came to us about 10 years ago with what looked like a simple a sinus node disease. He had a pacemaker done. His echo then was plumb normal, but in the last 2 or 3 years, his heart failure he's developed heart failure. We did an angiogram. We found that he had a circumflex stenosis. We stented that, and he looked fine. Now he's come back with VT, and we've done his angiogram again, and we found that his coronary arteries his stent is patent. There's no other coronary artery disease, but his LV function is globally reduced. So I got him to do a cardiac MRI this time, and in the cardiac MRI there is absent perfusion in the LAD territory, although the LAD has got no stenotic lesions. So we then went on to do a FTG PET CT for him, which shows that he's most likely got cardiac sarcoid. So you will come up with these surprises. So it is worthwhile, in the younger patients, it is worthwhile getting these evaluations done. So once your baseline investigations are done, involve a cardiologist and to see whether an angiogram is required, whether a CT angiogram is required, whether a perfusion scan is required, or even a cardiac MRI. And in patients where there's a family history of sudden cardiac death or there's a non-ischemic cardiomyopathy, particularly in the young patients, you should look at genetic counseling and testing to see if there is any inherited cardiomyopathy traits that is there, and that is something that should be looked at. So what are the treatment modalities even before you could, to ensure that your patients do not get into heart failure, those who are at risk? First and foremost is the most common things are diabetes and hypertension and lifestyle. If your patients are overweight, if your patients are hypertensive, if your patients are diabetic, if your patients have got history of excess alcohol intake, if your patients have got history of smoking, these are things that you as a physician should be addressing beforehand, because these left untreated will definitely at some stage the patient will either develop dilated cardiomyopathies or more likely ischemic cardiomyopathy. So address these patients and address these things which should be taken up. So this factor is important. In those patients who have got an ejection fraction of less than 40%, if you're using a drug for hypertension, then the first drug of choice should be an ACE inhibitor or an ARB, because we know that this improves asymptomatic heart failure and reduces mortality. In patients who have got heart failure, ejection fraction of less than 40% and hypertensive, ACE inhibitors should be combined with beta blockers and mineralocorticoid antagonists, because again, this is standard treatment both for hypertension as well as treatment of their heart failure. Is there any evidence for routine use of statins? Well, there is no evidence that statin improves heart failure treatment, but definitely there is no evidence that statins worsen heart failure. So given the benefit of doubt, we generally have most of our patients on statins, although we don't necessarily start that as part of their initial treatment. In those patients who had recent heart attacks or recent MIs, rather than going for an ACE inhibitor, we know that the ARBs are better. And now, in fact, there is growing evidence for the ARNI drugs to be initiated as a first-line drug in heart failure. So you will see probably in the next update, you'll have a 1A recommendation for ARNI drugs to be utilized. So all these are drugs which are things which will help. What are the things that you should not do? Things that you should not do is use thiazide diuretics, because they don't improve outcomes. They actually increase the risk of hospitalizations. You should not be using drugs like calcium channel antagonists, which I'll come back at a later date, which are the harmful drugs to avoid. When it comes to management of these patients, it is very clear. As I said, you want to catch them at stage 1 and you don't want them to progress to stage B or stage C. So what is it that you can do for these patients? You address all the risk factors, i.e. if they're hypertensive, give them optimal control of antihypertensive therapy. If they're diabetic, have an early use of SGLT2 inhibitors. Previously, we used to start all the patients first on metformin. There was some good evidence from the UK PDS that being on metformin reduces the risk of chronic heart failure. But I think we've got more growing evidence in favor of the SGLT2 inhibitors to be started earlier. So early use of SGLT2 inhibitors. In patients with cardiovascular disease, again, you want to make sure that their risk factors are all addressed, i.e., their lipids are addressed, their sugars are addressed, their blood pressure is addressed, they are on antiplatelets, they are on statins, and all these works. We are now getting a growing group of patients with cancers increasing and oncology drugs being used more often. You are getting a lot of patients who with exposure to the cardiotoxic drugs. Again, this you have to work with a cardiologist and a cardiologist with an interest in oncocardiology, not just every cardiologist. I'm an interventional cardiologist, so if you ask me to narrate all the umpteen oncology drugs and their toxic effects, I'll be looking at the books and then planning the treatment. But there are dedicated people who have got an interest in cardio-oncology who will work with that. So have a multidisciplinary approach. If you have a patient like this, involve your oncologist, involve a cardiologist, so let them work together. If you've got patients who've got first degree relatives with cardiomyopathies of some sort, do not hesitate to get these people to have early genetic screening and counseling, because it makes a difference. And I think now there are genetic genome testing units in almost every place. We have a very good center run by our diagnostic unit called Agilus. They have genetic testing for various cardiomyopathies and so on, hypertrophic cardiomyopathies, and we can pick these patients up early. Now, if you've identified patients at risk, do you need to do anything? Yes, you need to treat them. You need to look at their lifestyle, education, and changes, but also keep a watch on these patients by monitoring their biochemical markers. A proBNP test is a very good test, both in terms of using and assessing these patients. And when you have got established heart failure patients or patients with EFs of less than 40%, and you want to make sure that they do not progress, then the drugs that are available are ACE inhibitors, ARBs, ARNI drugs, beta blockers, and so on. And all of these patients, all of these technologies do work at various steps. Once we move on to the symptomatic heart failure patients, to the left of your screen, you can see in green. Green is all the drugs that has got mortality benefits. The ARNI drugs, the beta blockers, the mineralocorticoids, SGLT2 inhibitors, diuretics, all of these have got mortality benefits in patients with established heart failure. And despite this, if these patients are symptomatic, then you have to see what else can be done. Is there anything else that you can do in terms of improving their quality of life and symptoms? That is where drugs like hydralazine, nitrates, digoxin comes in. In terms of improving their outcomes, then you've got ICDs and CRTs. I will evaluate that in further slides. And if patients have got refractory heart failure, we then think about other concepts such as assist devices, transplants, or if the patient has reached the end of the stage, either financially or because of the disease process, it is not wrong to talk to them about palliative care. It is not wrong to initiate discussions about how we can wean down and give them a comfort life rather than just put them on medications or keep them in hospitals. This is a very old slide. This is 2005. This is when I went for my first heart failure conference in Rotterdam. And this was the slide that was put up by one of the senior cardiologists there. And we know that over the years, this is what has happened. We first were talking about digoxin, diuretics, and hydralazine. There was some benefit. Then came the ACE inhibitors. Then you found these major trials, CBIS2, Capricornus, which looked at patients with lower ejection fraction. We started using beta blockers routinely and ACE inhibitors routinely. Then the RILE study came, which brought back aldactone into the scenario. Until then, aldactone was more or less, spironolactone was more or less a drug which was being relegated to the shelves. But RILE study showed that spironolactone makes a difference in terms of reducing hospitalizations, reducing sudden cardiac death and improving quality of life. And after that, you had the heart failure device studies, which was a companion study, and CARE-HF, which again showed the benefit of CRTs and so on. So, ladies and gentlemen, I think if you take a bird's eye view, this is a very nice slide which you can keep for your reference. And this is way back from 2016 when the guidelines have documented this. The ones in green, the ones which have got the legend of green, that is sacubitril, valsartan, ACE inhibitors or ARBs, beta blockers, mineralocorticoid antagonists such as spironolactone or epileron, or now Kerendia, and devices, ICDs, CRTs, CRTP or CRTD, and heart transplant. All of these improve the morbidity and mortality. Which are the ones which can add-on drugs which can improve quality of life? It is digoxin, hydralazine, isolazine combination, and ivabradine. This again have got benefits. So if you remember that, that should be fine. Now, if you look at what are the guidelines in terms of treatment of heart failure, as I said, first step is to establish the diagnosis. First step is to address congestion by diuretic therapy. And the first step is to initiate guideline-driven medical management. What is guideline-driven medical management in heart failure patients? Well, you've got the 4 pillars of heart failure treatment. You've got the RAS inhibition, either with ACE inhibitors, ARBs, or ARNI drugs. You've got the sympathetic system inhibitors, nervous system inhibitors, that is beta blockers. You have the mineralocorticoid antagonists, and you've got the SGLT2 inhibitors. So all of your patients who come with symptomatic heart failure should be initiated on these 4 classes of drugs, and we call these as the 4 pillars of treatment. As you can see, therapies can be started simultaneously or without specific medication sequences and should not be delayed. This is what the guidelines tell you, and this is something that we could do. I always get the question asked, which one do we start first? And I said, no, you start all 4 of those, because these 4 drugs work on different mechanisms and they act upon and they help the patient. And the current guidelines is that you up-titrate these drugs as far as possible pre-discharge, and it has been shown that those patients in whom you aggressively up-titrate these medications based upon their tolerability and blood pressure and so on have a better outcome than those patients in whom it is started late. So once we do that, if your patients are still symptomatic, then are certain things that we can look at. We look at the ECG. We never forget to keep the ECG as a focus in your patients with heart failure, because that ECG is telling you how well your patient's heart is responding to stress and to the treatment. Over a period of time, a patient who has got a normal ECG will develop broadening of the QRSs, will develop a bundle branch block, either a right bundle branch block or a left bundle branch block. If your patient is optimally treated, the chances of that progression is slowed down. But annually or every 6 months, whenever you see stable heart failure patients, make sure to do 2 tests. One is an ECG and second is a pro-BNP. These 2 tests will tell us how your patient is doing, both electrically as well as in terms of the preload. If the patient is having silent heart failure, the pro-BNP will increase. If the patient has got slow progression of myocardial fibrosis, the ECGs will change. So an ECG is a very important tool that you can look at. If your patient has got an ejection fraction less than 35% and the QRS is broad, then these patients are patients who are at higher risk of sudden cardiac death. So in these patients, you should be thinking of referring them for a cardiac defibrillator implantation or an implantable cardiac defibrillator, or what we call as an ICD. If your patient's ejection fraction has improved more than 35%, and your patient is symptomatically stable, you can just keep a watch on them. On the other hand, if your patient has got sinus rhythm, the ejection fraction is low, the QRS is broad, then you should be thinking of cardiac resynchronization therapy. I'll come to that in a minute. So this is another important slide to keep in mind, or if you want to take a picture of that, feel free. So optimal medical therapy, follow them up. Class 1 medical therapy is 4 drugs: ACE inhibitors or ARNI drugs, beta blockers, mineralocorticoids, and SGLT2 inhibitors, which can be either dapagliflozin, empagliflozin, whichever is available. Both of them have got good data. Loop diuretics purely for symptomatic benefit. If they are symptomatic despite of these, then look at their ECG. If their ECG is narrow and the LV function is low, they are patients for ICDs. If the patients' ECGs are broad and they're symptomatic, then they're patients for cardiac defibrillator therapy. So what are the new therapies that have come? This is something which is worthwhile talking about, because these have made a huge difference in terms of how heart failure patients respond. The ARNI therapy, the SGLT2 inhibitor therapy, and I don't know if Finerenone is available. I'm sure it is available across the world, and maybe accessibility might be a thing. This is again a very selective mineralocorticoid antagonist. The SGLT2 inhibitors, it's a class 1 indication. So all your patients with symptomatic chronic heart failure patients should be either on empagliflozin or dapagliflozin, because it has shown to reduce hospitalization. It is shown to reduce myocardial mortality, whether your patient is diabetic or not. And it is also a cost-effective treatment. And the basis for that is this study is the way they work is they work on the glucose sodium cotransporter 2 channels. So all your patients who are on glyphosins will have excess of glycosuria, which will have a glycosuria. And the drug works in that it has got a mechanism which is varying in effect, but it is also known to have a superoxide effect, working on the antioxidant levels and so on as an antioxidant, and thereby improving the myocardial protection. You could either use dapagliflozin, you can use empagliflozin, or you can use candagliflozin. All 3 drugs have got clinical data in support of heart failure patients. The one which has made a huge difference in terms of the clinical data is this lovely study known as the DAPA-HEART study, which was a randomized control trial, which was published in 2019. We are now in 7 years down. This was the first randomized control trial using SGLT2 inhibitors in patients with heart failure, irrespective of whether they were diabetic and non-diabetic. This was in addition to standard of care, and we found that the study showed significant benefits in terms of outcomes. The follow-up was around 18 months. These are all established heart failure patients. These are all patients, nearly about 5,000 patients were recruited for these. The endpoint was achieved in 16.3% of the DAPA group as against to 21% in the placebo group. The p-value was statistically very significant, and the number needed to treat to avoid one adverse event was just 21. So if you treated 21 patients, 1 patient would survive. It had benefits both in heart failure reduction, it had benefits both in cardiovascular death, although the composite of these 2 was the one which was found to be statistically significant. So whether your patient was a diabetic patient or a non-diabetic patient, irrespective of that, if they had an ejection fraction which was less than 30%, then these patients should be treated with an ARNI drug. And if you look at the recommendations, it is all class 1A recommendations. Heart failure with reduced ejection fraction, NYHA class 2 to class 3, use of ARNI is recommended. Patients with previous history of chronic heart failure, despite being on ACE inhibitors, if the patient is symptomatic, change over to an ARNI drug. Patients who are intolerant of an ACE inhibitor, use an ARNI drug. All of these has been shown to be of benefit. Where is it harmful? You also need to know when not to administer these drugs. You should not administer these drugs concurrently when the patient is on an ACE inhibitor. So if you have a patient who's on, say, ramipril or perindopril or enalapril and you have heart failure, you have to discontinue that drug for at least 36 hours before you initiate an ARNI drug, because there was evidence that giving an RNA drug prematurely increases the risk of angioedema. So angioedema was something that was very important, significant. So we give out a washout period of at least 36 hours for those patients who are on ACE inhibitors before we start them on RNA drugs. You should not give this to any patient who has had any form history of angioedema. You should not give this to administer these patients within 36 hours. So these are the harmful factors that needs to be looked after. Otherwise, it's a wonderful drug, and believe me, it has made a huge difference in terms of outcome. And this is the Paradigm Heart Failure Study, which again looked at comparison with an ACE inhibitors, ARNI versus ACE inhibitors. This is a multi-center study. It's a randomized control study, which was looking at the combination of sacubitril valsartan compared to enalapril in patients with reduced ejection fraction. You had umpteen races, so it's not just restricted to a European population or an American population. There were patients from India, there were patients from Africa, there were patients from China. So the study was a broad-based study. So there was data for everyone. And you could see that those patients who were treated with enalapril versus sacubitril valsartan combination in all aspects, statistically significant. All-cause mortality better with reduction with sacubitril valsartan. Cardiovascular mortality better reduction with sacubitril valsartan. Risk of sudden cardiac death better with sacubitril valsartan combination. Risk of worsening heart failure significantly reduced, or a trend towards significant reduction in patients with heart failure. And a composite of all of these made a difference. So sacubitril valsartan combination significantly reduced the risk of sudden cardiac death and deaths due to worsening heart failure. It also prolonged life in comparison to enalapril by 2 years. 2 years is not a small time in patients with heart failure. And it showed that this is also significant. It had a better quality of life. So this is something that you need to think about. So if you've got heart failure patients, gone are the days of trying them on ACE inhibitors. The data is very strong in favor of a virgin start with sacubitril valsartan. How do you use these drugs? You start them at a low dose. In my Indian population of patients, I give them half dose. This is the European data or the American data. They say start with 50 milligrams twice a day. I start them at 25 milligrams, half the tablet twice a day. See them in a week's time in my heart failure clinic. My heart failure nurse looks at their blood pressure, looks at their creatinine. If they're fine, we give them a single dose, and they tolerate it quite well. Remember, the most important one is renal impairment. Keep a watch of that. If your patients have got severe renal dysfunction or hepatic dysfunction, you have to keep a close watch on them. I've got a lot of patients who've got kidney issues whom we still treat, but we keep a watch on them. Most importantly, do not give them concomitantly. And if there's an ACE inhibitor, stop it for at least 36 hours before you start the other treatment. And you do not use it in people who've got angioedema to either ACE inhibitors or other history. What are the side effects? Well, it's a very potent vasodilator. It works very well, works very effectively on the blood pressure. So you do get hypotension. You do get hyperkalemia. You do get a small proportion of patients who also have the cough because it is still working on the renin-angiotensin system or the RAS system. And in some patients, you can get worsening heart failure. So look out for these, and this is something that you can use for. And I would recommend that anyone who is practicing heart failure in this day and age should be using sacubitril valsartan instead of ACE inhibitors or ARBs. The other drug that is recommended is a beta blocker. And again, which sort of beta blocker should be used? Well, you don't give atenolol to heart failure patients. This is long acting. It has got a prolonged effect both in terms of heart rate reduction, heart rate impact on heart rate and on the blood pressure. And if you and I know that well, we know that both of these thing affects heart rate and your high blood pressure is the one which contributes to the cardiac output. So when you start your heart failure patients on beta blockers, remember to start with a short-acting drug. Remember to start at a low dose. Remember to build it up slow. So low and slow is the buzzword for use of beta blockers in heart failure. Your patients for the first week to 10 days will feel very rough, because what it does, a beta blocker reduces the heart rate, which is one of the compensatory mechanism a patient with heart failure gets. They have tachycardia, it reduces it. Two, it reduces the blood pressure, which is again something your patients with heart failure are thriving on. But this dip is only momentary. In the first week or so, you will have. So tell your patient, educate your patient that, look, you will feel worse with this drug when you start off, but it will get better with time. And as you do, once the first 2 weeks are gone, then it is an upward curve. Your patient will get symptomatically better, will have better mortality outcomes, will have a better quality of life, will have less cardiac arrhythmias, and hospitalization will be reduced. So which beta blockers you can use? Well, you can use either bisoprolol, you can use either carvedilol, or you can use metoprolol succinate. Any of these drugs have got good effects. The drugs that I would not routinely use are drugs which have not been studied, i.e. Atenolol or nebivolol. Nebivolol has not been looked at in chronic heart failure patients. It's a good drug for patients with hypertension, but in terms of chronic heart failure, it's not been looked at. Bisoprolol is what I routinely use because I use a lot of ARNI drugs. So I use the bisoprolol because it can be given as a once daily dose in patients. So I give my beta blockers in the afternoon. I give my ARNI drugs in the morning and night. So there is a lesser impact on the blood pressure. So patients' compliance with drugs, patients' tolerability of these drugs is improved. So this is something that you should look at. So a beta blocker is necessary. In terms of ARNI, in terms of the mineralocorticoid antagonists, spironolactone or epileron, any of these are beneficial. If your patient has got persistent hyperkalemia, or if the patient is developing hyperkalemia without any significant drop, you can use the newer drug that is Kerendia. It is a bit more expensive compared to your off-license spironolactone, but it works in those patients who got hyperkalemia because finerenone has got a lesser impact on hyperkalemia compared to spironolactone or epineron. When do you start these? And again, what is the dosage? Spironolactone is the drug which has got impact on patients who got chronic heart failure. You don't need too high a dose. The spironolactone drug was studied in two doses, 25 milligrams and 50 milligrams. The impact in terms of heart failure endpoints was the same, whether it was 25 milligrams or 50 milligrams. But with 50 milligram dosage, you had a higher incidence of renal dysfunction, you had higher incidence of hyperkalemia, and also you had higher incidence of painful gynecomastia, which caused patients to discontinue the drug. So for all technical purposes, spironolactone 25 milligrams in heart failure is more than sufficient. You don't need to increase it any further. But when you start it again, you start the drug today and you check the creatinine and the potassium levels in about 3 days to a week. If someone develops hyperkalemia as a result of it or renal dysfunction, it is a dose-related, it is a drug-related impact rather than a dose-related impact. So if they're tolerating it, you can leave it at 25 milligrams. There is no indication to increase it to 50. Epileron has got data in acute heart failure, i.e. post-MI heart failure patients. The epileron has got more data. Kerendia is the drug which can be used instead of these two drugs in patients who have got persistent hyperkalemia or a tendency towards hyperkalemia, or in patients who got renovascular disease, because there is growing evidence that routine use of Kerendia helps in reducing the proteinuria, helps in preserving the renal function, reducing the time or increasing the time between diagnosis of renal failure and dialysis. So it is something that is used, and in combination with diabetes, It is a drug which is now routinely been recommended. So if you've got access to Kerendia and if your patient can afford it, do not hesitate to use that. Then we move into the stage of the supportive drugs such as hydralazine nitrates. These are for patients who cannot tolerate the conventional medications such as ACE inhibitors or ARBs or beta blockers. For some reason, it is of benefit. It has been shown to be of benefit in Afro-Caribbean population in patients who've got NYHA class 3 and class 4. Addition of hydralazine and isosorbate dinitrate is recommended to improve quality of life. And there is some mortality benefit only in this class of patients of Afro-Caribbean origin, not across the board. So for your patients, it is something that you can use at an earlier stage. There are other drugs like vericiguat. Vericiguat is a drug which is a novel drug. It stimulates the glycinase cyclase mechanism and it improves the cardiac function. This is something which does not have mortality data. So in my books, I call it as a super digoxin, but people get very upset with me when I call it super digoxin. But if you look at the clinical data, that's what it is. So this is a drug I add on when I've given everything else and the patient is still symptomatic. Provided their pro-BNP levels are slightly on the lower side, it is not that beneficial in people who've got very high pro-BNP levels. So you can use this as an add-on drug. So this is another summary slide of what are the add-on drugs and what are the add-on procedures that we can think of. Now, we've done optimal medical therapy. If you've got a patient who's got ischemic cardiomyopathy, you can consider them for surgical revascularization, although it's a higher risk. If the patient has got secondary mitral regurgitation, i.e. because the ventricle is so stretched and dilated, there is poor coaptation of the leaflet. So if you've got secondary mitral regurgitation, in these patients, CRT therapy can work, a mitral clip can work. There is another coronary sinus-based procedures wherein we shrink the mitral annulus, which can also work. And these are all things that can work. So if your patient is still symptomatic, do not hesitate to refer them to a dedicated heart failure specialist who will look at it. Again, if you look here, this is numbers needed to treat. This is a slide summarizing all the various drugs that I've spoken about, wherein it produces how much of reduction it takes and what is the numbers that is needed to reduce the mortality. And all of these technologies do have significant benefit. And you can look at these single-digit ones, CRT in selected patients in where the patient's indications are there. A low number, if you treat 8 people, you can save a life. Similarly, in terms of beta blockers and across the board, these are all proven drug therapies which has got ability to save lives. So I think in the past 25 minutes or so, I must have given you enough information about the various drugs and why they need to be done. Now I want to tell you what not to do in heart failure. And this is also equally important. It's good not to provide any, it's okay not to give drugs which do not have any benefit, but you should also not give drugs which can cause harm. Most important is drugs like calcium antagonists, whether it is dihydropyridine channel blockers or non-dihydropyridine channel blockers. Calcium channel blockers is a no-no in patients with heart failure. So whether it's verapamil, whether it is amlodipine, cilidipine, none of these, or diltiazem, this should be avoided in heart failure patients. Is there any routine indication for giving these coenzyme Q10 inhibitors, enzyme supplements, multivitamin supplements? Well, there is no great evidence that it should be routinely given. Routine use of class 1 antiarrhythmics. Do not add patients on flecainide, amiodarone, and so on, unless there is a clear indication for that. In patients with heart failure, in patients who've got non-sustained ventricular tachycardias or tachycardias, then amiodarone does have benefit, but routine use, no benefits as such. In terms of your diabetic patients, the drug to avoid in heart failure patients are the DPP-4 inhibitors such as sacagliptin, linagliptin. They increase the risk of hospitalization. So if you have a heart failure patients, avoid these drugs. The drugs to use, as I told you, are SGLT2 inhibitors to start off with, and followed by metformin. Both of these have got data in terms of patients. Avoid using excess of non-steroidal anti-inflammatory drugs because basically they retain motor fluid and they worsen heart failure, they worsen renal dysfunction, and should be avoided. Are you still with me? Do you want me to go ahead for the coming few slides?
Yes, sir. Yes, sir. Please go ahead. We are with you.
Any questions?
There are few questions which have been typed. Do you want to take them now, or do you want to take them in the end?
No. I can take a break and answer their questions. Not a problem. I'll stop. Hold at this slide because this is what you can all do at your practices. The coming few slides is when you have to refer, and these are things that we can do for these patients. So I think this is towards the end of my slide. So what needs to be done for heart failure in terms of detection and management at your end is what I've spoken so far. The coming few slides will be about when to refer. So I'll take the questions as they are now and then progress.
Okay. So there are a couple of questions from Dr. Ivan Ipavu. Dr. Ivan Ipavu is from Uganda. So his first question is, why can beta blockers initially worsen symptoms before improving survival?
I think I did allude to that. Is my video on?
Yes, sir. Video just got turned off. Now on again.
Yeah. No, basically, see, these are drugs which have got an impact on the heart rate. These are drugs which have got an impact on the blood pressure. So a heart which is failing is got both an ability to, it is thriving. The compensatory mechanism is by increasing the heart rate. So if you give a beta blocker in the first instance, it slows the heart rate. So heart takes time for it to adjust. Second is a beta blocker is still an antihypertensive drug. It reduces the blood pressure. So heart rate and blood pressure both being low, it reduces the cardiac output. So patient feel a bit rough before it start. But over a period of time, within about a couple of weeks' time, this impact is settled down and patients tolerate this better. So that is why you should always counsel your patients about the initial dip. So if they take that through, a lot of patients in the studies were complained when they had the quality of life assessments that the first few weeks were very bad, and some patients left these drugs. So these are patients. This is the counseling that we have to do when we start the beta blockers. Tell them that, look, you will get better, but the first 2 weeks you might feel rough. Hang on there and it'll get better. And again, if you had a heart failure clinic, if you had a heart failure nurse, there'll be a very good liaison for your patients. You may not have the time. Hello?
Yes, sir. Please go ahead, sir. It was accidental.
Okay. So counsel them about it, and then, as I said, it's an upward beneficial role.
So another question from Dr. Ivan is, can BNP be normal in acute heart failure? And how does BNP help distinguish cardiac from respiratory dyspnea?
BNP is because of stretch or stress on the myocardium. So if you've got a BNP which is normal, it means that there is no myocardial stress. So there is no release of the natriuretic peptide. It is a response to that. So having a normal BNP will tell you that the cause for your symptoms, for your patient's symptoms, is non-cardiac. So it's a very good tool, whether you use ProBNP or BNP alone. Both of them have got different reference values, but this is recorded and it is very clear. So if you have a patient who's got normal BNP, a normal ECG, then the chance of this patient having heart failure as the cause for the acute deterioration is very unlikely.
So is another question is, how does BNP help distinguish cardiac from respiratory dyspnea?
I think that's what I've answered. Yeah.
Okay.
Normal BNP implies that the cause for your patient's heart symptoms is non-cardiac. It may be respiratory, so it's worthwhile looking at that.
Okay. So, another question from Dr. Vaiswa Kaziba from Uganda. So, severe ascites in patient with heart failure, liver cirrhosis, edema in a 98 YLM with normal BP. So, you shared some patient conditions. So what are your, I mean,
So
if you have any.
what he is describing numerically is, or with the clinical status, is that of a patient who has got congestive cardiac failure.
Yes,
Congestive
sir.
cardiac failure is a combination of both right and left heart failure. If your patient has got this patient usually should be hospitalized. If not possible, then make sure that they are on appropriate diuretic therapy first. They need to be decongested, keeping in mind their creatinine, keeping in mind their liver function tests. So these patients should be
So the
monitored
patient has liver
regularly.
cirrhosis as well, sir. So basically, condition is severe ascites with heart failure and liver cirrhosis and
Uh,
edema in 98 YLM.
Symptomatically you treat them as anybody else. If the renal function is good, if there's no hepatorenal syndrome, you can treat them with the conventional drugs. In this case, maybe we would use a higher dose of spironolactone. Now there is growing evidence if these patients are in class NYHA class 3, class 4 patients who need hospitalization, there's a very good drug that we use called acetazolamide. Acetazolamide we use, or Diamox is what we use, and it has been shown that giving them either oral or intravenous Diamox in addition to loop diuretics also improves the diuresis quite well and improves the resolution of heart failure or CCF much quicker. So a lot of patients of ours now, when they present with acute heart failure like this, wherein they are in congestive cardiac failure or in acute LVF, we add on acetazolamide in addition to the conventional drugs, and it's been shown to be of benefit as long as the renal functions are not too bad. If the blood pressure is low, there is some benefit, the role for use of dopamine, although there is no long-term large randomized control trial data. I am someone who believes in dopamine. I have seen it work, and particularly if the patient has got right heart failure and valvular dysfunction, adding low dose or what we call as renal dose dopamine makes a huge difference in addition to the diuretics.
So now we have a couple of questions from Dr. William Gadaga. Dr. William Gadaga is from Zimbabwe. What is the risk of recurrent UTI with SGLT2 inhibitors?
Very good question. Very good question. See, the way the SGLT2 inhibitors work is by producing glycosuria. So glycosuria is a nidus for balanitis or genitourinary infections in women. So the incidence is quite high. So when we are talking about 5 to 6% in terms of risk of infections. So when we counsel these patients, we always tell them about two things. One is that you ensure that hygiene, personal hygiene is paramount, and two, if you develop any inflammation, particularly in the men, if they have any balanitis, or if women have got frequent burning maturation, we tell them to get a urine sample done, look for culture and sensitivity and infection. If there is evidence of infection in the presence of this, then we take the SGLT2 inhibitors off. But it is something that should be counseled when you start these patients. Yes, very good. I failed to highlight that when I was talking about SGLT2 inhibitors.
So another question, Dr. William, is what is the role of dobutamine in acute heart failure?
No beneficial role as such, but if you got a patient who is profoundly hypotensive, you could start that to improve their cardiac output. More of us are now moving towards noradrenaline rather than dobutamine. Giving dobutamine in the long run is like flogging a dead horse. You're going to transiently increase, but not of any benefit. So we no longer routinely use dobutamine. It's only to tide over an acute stage where the patient is profoundly hypertensive.
Okay. So now we can move to, so far we have covered all the questions that have been asked. Now we can move to the next section of your talk.
Excellent. So what is it in advanced heart failure patients? You've done all these patients, you've done all these things. What else goes further? And this is where the patients with heart failure are statistically at a higher risk of sudden cardiac death, and they are at risk of progressive heart failure. And we can do a lot of things for these patients. One of the key things that has happened in the past, say 20 years, is cardiac resynchronization therapy, or CRT therapy. So what is CRT therapy? This is a device-based therapy wherein we place 3 wires. We position an atrial wire, we position a right ventricular wire, and then using the coronary sinus, we use the lateral cardiac vein. A lateral cardiac vein is very important, and we basically synchronize the top of the heart with the bottom of the heart. And how does this work? It improves the dysynchrony. As you can see here, there is clear dysynchrony. This is an echo-based image. You're looking at the lateral wall and the septum. When the septum contracts, normally in a normal ventricle, the septum also contracts simultaneously. But here you can see there is a significant delay. So rather than the ventricle, I don't know if you can see my video now. Can you see my video also? Or is just the slides?
It's just a slide, sir.
Okay. Let me go back to the video. Are you able to see me now?
So we are able to see like in that infinite kind of a screen loop.
Acha. So rather than the ventricle, let me go back to the slides then. So this is what is called as left ventricular dysynchrony. So when this happens, by putting the CRT therapy on, you're able to synchronize the ventricle in such a way the lateral wall and the septal wall contract simultaneously, and there is good benefit in terms of what it does. So by doing this, we pick up patients who have got advanced heart failure, who have got left ventricular dysynchrony. And what does this do? This improves the ejection fraction by around 8 to 10%, 6 to 8% in most data, but in some super responders up to 10%. It reduces the mitral regurgitation, which happens as a result of the left ventricular dilatation. Therefore, it also reduces the left ventricular, the pulmonary congestion, and quality of life is also improved in that cases. And we also synchronize. By doing this, we are also able to get a better right and left ventricular or biventricular synchrony. So these are patients whom you need to look at in those who've got advanced heart failure. In those of those patients in whom there is an ischemic cardiomyopathy, i.e., people who've got heart failure as well as coronary artery disease, they are at a very high risk of sudden cardiac death because of cardiac arrhythmias. So by implanting a defibrillator, we'll be able to reduce that also. So this is what happens in a patient who has got an implantable defibrillator. You can see a sinus rhythm here, you get a ventricular ectopic, it produces an RNT, and then it starts off with a fast ventricular tachycardia. Usually this is scar mediated, and so when we put a defibrillator, we do what is called as anti-tachycardia pacing, and in about 90% of the patients this works and the patient is stable. In some patients they have slow VT, so we program it to monitor it much longer, because most of the slow VTs settle down spontaneously. If it doesn't, then it does the same thing of anti-tachycardia pacing. If that doesn't work and the patient goes into a more accelerated VT, we deliver a shock. And this is therapy which works. And this is how CRT therapy is done. This is a cardiac defibrillator lead kept in the right ventricle. We then access the coronary sinus, and we then pass a wire through the coronary sinus, and we do a venogram, and we find a nice lateral cardiac vein. That is very important, that we find a nice lateral cardiac vein, because putting a lead into an anterior position or in a posterior position does not make any difference. It should be a posterolateral cardiac vein, and that is where it helps in improving the cardiac function. So we place that lead. We then position the final lead. So we've got three leads. We've got the atrial lead, you've got the ventricular lead, right ventricular lead, and then we position the left ventricular lead. So by doing this, we are able to synchronize the electrical contraction. We pre-excite the lateral cardiac vein first, and then the ventricle comes and contracts together. And this is a therapy which works very well. And in patients who have got sinus rhythm, who've got a left bundle branch block, which is the QRS width of more than 130 milliseconds. For a general physician, these are the only two things that you need to look at. Your patient is symptomatic. Yes, despite optimal medical therapy, yes, he's symptomatic. 2, is your patient having a left bundle branch block on the ECG? 3, is the patient got sinus rhythm? 4, has the patient got more than 1 year's life expectancy? If these 4 are there and the patient is symptomatic, this is the ideal candidate for cardiac resynchronization therapy. It can be either with a defibrillator or without a defibrillator. We use a defibrillator in patients who've got history of coronary artery disease. We use a non-defibrillator CRT therapy in patients who've got dilated cardiomyopathies, and both of these work quite effectively. So remember that. Also, if you've got patients who've got complete heart block and they've got left ventricular dysfunction, these are patients in whom a conventional pacemaker, a dual chamber pacemaker, is not recommended. These are patients in whom we should put a lateral cardiac vein lead, or now a newer concept of physiological pacing is coming, but that is still in early stages. A proven therapy for this is cardiac resynchronization. So if you got patients who got ejection fraction of less than 35% for an optimal medical therapy, then they should be considered for an ICD, because heart failure patients with ejection fraction of less than 35% are at high risk of sudden cardiac death. If patients who've got heart failure symptoms, who got an ejection fraction of less than 35%, have got a left bundle branch block, are in sinus rhythm, on good drugs, they are also candidates for CRT, but they are CRTD. What's the difference between these two? A CRTP is a pacemaker alone used for heart failure therapy. CRTD is a pacemaker cum defibrillator used for heart failure therapy plus sudden death reduction because of ischemic cardiomyopathy. Am I clear on that, or did I tell too many things?
No, so it's clear.
Oh, good. The other things that you can think about are for advanced assist devices. This is something which is available, wherein we use a left ventricular assist device. An assist device is nothing but a device which has got an external pump. So this is a high energy pump. So we empty the left ventricle by putting inflow tube into the left ventricular apex. This then goes through a pump, and then the outward outlet is connected to the aorta. So you're essentially doing, the assist device is doing what the heart should be doing by positioning a pump outside. This is then placed underneath in the chest wall, and there is a drive line which takes the cable out. This is connected to batteries, and the patient wears this and walks around. This is something which is done quite effectively. This is called left ventricular assist device, or LVAD. This is an LVAD which has been put about, we do a few LVADs a year. You can see in this image, this is the pump. This is the outlet being connected to the aorta. And this is the drive line that is coming out through here. This is done by my surgical colleagues, and patients are admitted under me. We optimize them and then we stabilize them and then send them across. And it is quite an effective treatment. There are different devices. This is called HeartMate 1, HeartMate 2, HeartMate 3. HeartMate 1 is no longer in circulation. HeartMate 2 and HeartMate 3 are available. There is a huge cost implication. In Indian rupees, it's about 80 lakhs. Varun, you can tell them how much it costs in African money or in dollars.
So, sir,
And
now roughly it would be like 78,000 USD or roughly 80,000.
38,000 USD, yeah, 80,000. But it is something that works very effectively. Now this is how it is. Now this is the LVAD which is put in my patient. You can see this is coming out of the left ventricular apex. This is the pump, and it comes all the way and it is connected to the aorta. This is one of my patients. He's a 48-year-old now. He was 44 when we put the assist device in. He's from Cameroon, an excellent gentleman, a very well-educated guy. He was a lawyer. And he designed his own vest. He stayed with me for 3 months before we did the LVAD for him. He stayed in hospital for about 4 weeks and then stayed in India for another 2 months. So a total of 6 months he was in India. And this is him after he goes back to Cameroon. This is how he came. And this is how he has. He now has another child. So if you want to market this as another tool for a better life, then he's a good example. He wanted a daughter and he's got another child. And this is now 4 years. He came recently to have his batteries changed, and you can see he's doing quite well. And this is technology which is available. Patients can come from the African countries, get this done. They will need to stay for at least 2 to 3 months with us. And the visa processing can be done through Varun and his team. And this therapy works. In fact, just last week, I spoke to a gentleman from Nigeria who's also got advanced heart failure, and he's planning to come across. And this is something that is doable. Heart transplants is also something which is available at our place. Well, you probably, none of you might have seen this videos. This is a heart being taken out from a 27-year-old, and this is a transplanted heart which is functioning straight after the surgery. So, ladies and gentlemen, I think I've gone through the length and depth of heart failure management, hopefully not confused you a lot. But the key things that you need to recognize is that early recognition and diagnosis of heart failure is the key thing. Systematic evaluation of patients and the risk factors, including the family history, is mandatory, because you might have some family members who might have had late onset of heart failure in their 50s. And if we pick these patients up, give them prophylactic drugs, or keep a watch on them, we might be able to catch them early before they present with advanced stages. Early use of guideline-driven medical therapy will ensure better outcomes. This is one of the very well-researched fields in cardiology, heart failure management. Every single drug that we use has got mortality benefit, or if not mortality benefit, morbidity benefit. If not morbidity benefit, it has also got data to say which drugs to avoid and when to avoid. In advanced heart failure patients and symptomatic heart failure patients, there is definitely a very good role for heart failure therapies such as ICDs and CRTs. I am an avid user of CRT therapy. In fact, I trained in the UK, and one of my brownie points or distinction things was that I started the heart failure therapy day of CRT therapy. When I got appointed as a consultant at Wolverhampton Heart and Lung Center, my hospital was doing 12 CRTs a year. When I left in 4.5 years, 5 years, we were doing 120. And there was an exponential increase, not because I was crazy about it. There was a huge demand. And because of that, I was given a Clinical Excellence Award for having established that service. So this is therapy that works. I can tell you from first-hand information about the benefits of these therapy. And in select patients, LVADs and heart transplants also have got excellent outcomes. So if you got a patient with advanced heart failure, do not just stop at medications. Think about how we can improve their quality of life and how we can improve their longevity. And in terms of longevity improvement, it is ICDs and CRTs which makes a difference. In terms of patients who are not suitable for ICDs or CRTs, then assist devices like LVAD and heart transplants have definitely got excellent outcomes. I think this is a summary slide about what I have spoken about, the 10 take-home messages. If you want, I'll read them out to you. I'm not sure whether it's very clearly seen. Guideline-guided medical therapy for heart failure with reduced ejection fraction now includes 4 medications, which is beta blockers, which is ARNI drugs or ACE inhibitors or ARBs, mineralocorticoid antagonists, and SGLT2 inhibitors. We have got good recommendations for all of these drugs. We should be continuing these medications for these heart failure patients. It's not that we start and stop them. There is benefit in continuing these. A routine use of non-invasive assessments such as pro-BNP assessments, echo, things definitely makes a difference. If you have a heart failure clinic, that definitely makes a huge difference. And one of the things that happens with heart failure clinic is that there is standardization of care. This is what I do. This is what happens in my practice. Let me see if I can get to that slide. Yeah. So patients get referred to my heart failure clinic. I see them or one of my colleagues who has got an interest in heart failure. It's not possible for one man to run a clinic. So you have another colleague. We have a dedicated heart failure clinic. We do a heart failure package wherein we do all the blood tests, the pro-BNPs, the full blood counts, the renal function, liver function tests, ECG, chest X-ray, and then we identify the cause. We ensure that the medical treatment is started off, and my heart failure nurse monitors them closely. We give her clear instructions as to when we need to check the renal functions, when the patient needs to be brought in, and then we have a look. Then once the patient is stabilized, we then assess for risk of sudden cardiac death. If you got patients who are well established, whose heart function is improved, we tell them to come once a year and we discharge them back to the general physician. If the patient is still symptomatic, then we see how best we can improve them. Are they candidates for cardiac resynchronization therapy? Are they candidates for ICDs? And once that is done, they are under regular follow-up with the heart failure clinic. They see me, say, if they see me once in 6 months, they will have had a telephonic conversation with my heart failure nurse a couple of times in between. If they've got refractory heart failure, then we do advanced imaging such as cardiac MRIs and biopsies, and then we look at transplant assessments or LVAD assessments. So these are all the things that we do in the heart failure clinic, and it works very well. And it is something, if there's anyone there who's listening to me who's got an interest in heart failure, then it is worth investing in a heart failure clinic, because it encompasses the whole gamut of investigations, the whole things that is managing for these patients. So these are my contact details. I'm the Director of Cardiology at Fortis, Bannerghatta Road in Bangalore. This is my mobile number. This is also my WhatsApp number. If you have any patient query related to cardiology, be it heart failure or coronary artery disease or TAVI, you can contact me directly, or you can contact through Varun or your local liaison people, and we'll be able to help you out. Even if it means just taking some courtesy advice about whether things are you're doing it right, I have no problems with that. I generally don't answer phone calls that easily, but you can definitely message me through that. I hope this has been useful, and I hope it's not been too extensive. It's very difficult to cover the whole of heart failure in a short 40-minute talk. So if I've taken a bit more of time, I hope it's been of benefit. Thank you very much, and I'll take any more questions if you have.
There is a question. Doctor has not displayed his name, simply says Zoom user. When should the Sgarbossa criteria not be used?
Say that again, please.
When should Sgarbossa criteria, SGARBOSSA criteria not be used?
I don't know. You tell me what did you say? SG?
So can you access chat? SGARBOSSA. Maybe it's a typing mistake. Sir, whoever has asked this question, can you clarify?
Okay, okay. This is not in relating to heart failure at all. Sorry, that's why I was wondering why is this being asked for. This is not. This is looking at a left bundle branch block and acute myocardial infarction criteria. If you've got a patient who's got chest pain and they've got a left bundle branch block, it is difficult to decipher whether this is an old or new. So we look at something called ST elevations. So if you've got a 4 millimeter ST elevation, despite being in left bundle branch block, we still consider that as an acute myocardial infarction, and we use that as a criteria. But that does not apply for this talk, I'm afraid. That we are talking about heart failure. You got me off track. I was wondering, what is this? Yeah.
No issue, sir. But I think, sir, any more questions? Even if if it's not directly related to heart failure, but
Yeah,
cardiology, so that we can ask Dr. Rajpal Singh, and we can raise it.
definitely you can. Definitely you can. And we, as I told you, we have a very good array of a range of treatment, right from pediatric cardiology to adult cardiology. I'm supported with very good surgeons. The practice that we have is entirely evidence based, and I personally uh, uh, have got a rich experience for the past 30 odd years, having worked in the UK and here as an independent consultant for the past 15 years. We have got state of art technology. We've got a fully equipped two cath labs, one with a biplane cath lab, and we do cutting edge. Almost every cutting edge technology is practiced here. We now do leadless pacemakers, we do CRTs, ICDs, we do physiological pacing, complex coronary angioplasties, TAVIs, structural heart disease. All these are available. Uh, if one wants to have telephone conversations with us before you send a patient across, or if you got patients who prefer to talk to a cardiologist, and I'm sure Varun can arrange for those liaisons.
Dr. Rajpal, they are aware. So basically, every doctor in the network, they have a relationship manager. And what
Right.
we
Okay.
follow is, we also know that doctors like you keep very busy. And what we follow is, a very well documented standard. So if there is a
Uh-huh.
patient, so
Yeah.
the relevant reports, the relevant history capture, because the doctors on the African side, they do it. So that's why we
Yeah.
keep everything very well documented. And then it is reviewed by them for completeness and
Right. Yeah.
accuracy. Once it passes that process, only then it is shared with you or your
Okay. Yeah.
peers, so that you have
Mhm.
right information, and can give a meaningful opinion, and can highlight any gaps or suggest any investigations that need to be done at their end. So this is how we do, sir. And once the opinion is present, our doctor partner presents the opinion to the patient, and the patient wants to move ahead, then we request a consultation with you, and then the whole process moves ahead. That visa and all the logistic support, the Fortis international team, they step in,
Yeah.
they assist and everything. So what I want to say is, if there is any cardiac query, not only related to heart failure, like as Dr. Rajpal shared, that it's not just heart failure, but Fortis being the leading healthcare brand, and Fortis having, whole capabilities which covered the entire gamut of cardiology, and also Fortis Bannerghatta Road. It's a multidisciplinary hospital. So many times somebody with a heart failure, or somebody with acute cardiac condition may have other morbidities, comorbidities as well. So
Correct. Yeah.
the availability of a multidisciplinary team is here. And if you have any case to share where you want review, let's say even if you're not sure whether the patient wants to come ahead to India, but if you want a review and input, we will document it and we'll share it with Dr. Rajpal's team. And within a reasonable time frame, like we cannot promise that because sir could be busy, but like within 24
Yeah.
hours or 48 hours, some either him or somebody relevant doctor from his team will review and give their inputs. So this is what
Yeah.
we do and maintain. And so there's a follow-up question from Dr. Ivan. Uh, thank you. He wants you to explain Frank Starling mechanism in children.
I'm not a pediatric cardiologist. I'll let that question go by.
Okay. Dr. Ivan, when we do a pediatric cardiology session, you can save this question for that. So, sir, I think your talk has been quite detailed. I hope
Yeah.
everybody found it useful. And what we do after this masterclass session, we share the summary of transcript also, so that
Sure.
whatever was discussed today in the session, they can have access to it, as a guideline or something. And
Excellent.
thanks everybody for their time. Although the session was longer than the expected duration, but it was quite engaging, sir, and it was very useful.
Thank you
So,
very much. Like, as I said, heart failure is not something that we can cover in 20 minutes or 40 minutes. And given that this is across a continent, it is better to talk about what they can do at their end and when they can refer, and which was the gist of what we did. And unless I elaborate on what we are able to do on this end, it would be very meaningless. So if it's been long, my apologies, but I hope it's been given
no,
you a
no,
good insight about what's
no,
available.
so you can see the doctors have been staying. So, I
Yeah,
mean, I
yeah,
think
yeah,
the
yeah,
doctor community is trained for long surgeries. I mean, it's part
yeah.
of your training. But the advantage with Geo is, and that's what we want to highlight, that we have built this
Yeah,
structure, infrastructure, so that let's say Dr.
yeah,
Ivan, who is practicing in Uganda, and if
yeah.
he has a case where he needs that your input or your team's input may help, so it becomes so easy for them. Otherwise,
Correct,
document the case, get it shared with Dr. Rajpal, and together with your inputs, the patient gets clarity also whether they can be managed
correct, correct.
locally or they even need to come to India, or and as sir, as I was discussing with you when I was briefing you about the master class, that one-time surgery or one-time intervention is just one part of the care continuum. So
Exactly. Yeah, yeah.
this connection, like specialist
This relationship is
being
important. Yeah,
you and the local doctor being empowered. This is what the crux of Jivo model is, so that this healthcare continuity is
fantastic.
maintained. And
I think you're doing a fabulous job. I hope it's of benefit and it is transferred across to the patients, because I see heart failure patients on a regular basis, and timely treatment, timely initiation of treatment, and communication makes a huge difference. And the number of patients that we see who are very happy with people who talk about their care, who explain to them why they're doing what they're doing, is very important. And I think that's some link that your doctors there can develop with me. I may, as you rightfully said, I may not be able to respond straight away, but more in most cases, within 12 to 24 hours, you will get a message back from me about the patients, as long as all the data is shared. So good.
okay.
Thank you very much, and I think
Thank you,
it's
sir.
been a
If we have your permission, so we can conclude. If there are any follow-up questions, right now I'm addressing the GU doctor community. If you have any follow-up
yeah,
questions around this topic or anything around cardiology, please feel free to write on the group, the coordination group that we have with you. We will share it with Dr. Rajpal and his team, and within a reasonable time frame, I'm confident we'll get the response also and share it back with you. And the idea of GIVO is not just about treatment in India. Many times you may face difficult cases to manage, and you may be aware that the patients do not have means to, undertake a trip or etc. But you may feel that if some specialist could just have a look and just give me pointers. So please document the case. If we document it well, it is easy for Dr. Rajpal or his team members, and to give you a confirmation or some clarity about how that can be approached, because together all of us are working in improving accessibility to excellent healthcare and the right treatment path. So thank you, sir. Thanks for your time, and thanks everybody who
Yeah.
attended. It was really a wonderful session.
Thank you all. Thank you. God bless. Thank you.